Today is, out of the 3 days, hopefully the last 2 days has been enjoyable and educational and worthwhile on multiple levels. We try to build in time actually for people to learn things, to interact, to meet physicians, scientists, and most importantly to meet each other. And from distant observations, it seems we've done well, especially at the less than 16 and under level. We've got a few poker games going on next door, so if anyone wants to buy in, I think Landon's dealing. This morning is supposed to be very interactive and is usually a lot of fun. One of the questions, there are 2 questions every year. I think the physicians at this meeting get asked at least 12 times individually. One of them is, should I take my vaccinations? Or should my child take the vaccinations? And the second is, what's happening with stem cells? So I'm going to punt on the vaccination question for right now and move on to the stem cell question. And we thought, since it's such a big topic and such a big issue, instead of leaving it for the open panel discussion, we'd start off the morning with a presentation by Mike Levy from Hopkins, giving you an overview on what's happening in stem cell research, where we are, where we're going, what are the obstacles we have to overcome, and how we're going to do it. So I'll turn over the stage to Mike.
So I'm glad to see a patient audience here today. I gave this talk yesterday to the scientists before we launched into the stem cell research talks. And I think this is a good talk because it gives a broad overview of stem cell biology for neuroimmunologic diseases, specifically transverse myelitis, MS, and NMO. So I hope this helps so that when we sit up here on the panel, we all have the same vocabulary. You all know kind of what the current status is, what clinical trials are going on, and how you can participate. First, I just want to mention that Hopkins has over 130 stem cell researchers in every different field, and that includes neurology. My specific focus is stem cell biology in neuroimmunology, again, those particular diseases. So I'm going to define stem cells for you. I'm going to list out a few of them and describe them in more detail, some of the science going on in stem cell biology and the clinical trials. First, I just want to mention that in my clinic, I run a neuromyelitis optica clinic at Hopkins, and I get patients all the time. They come in and they say, I'm here to put my name on the stem cells trial list so that when you, Dr. Levy, run your first stem cell trial, I want to be called. And you know, it's always my hope that I'm going to start a stem cell trial as soon as possible, but the reality is it's probably going to take a couple of years or more. And I just want to play this video for you because it sort of highlights what my patients are hoping for when they come see me. This is a commercial that Christopher Reeve put out during the Super Bowl. You know, Christopher Reeve, Superman, was paralyzed from the neck down and started a foundation to fund and advance stem cell research, and he put this out during the Super Bowl. Oops, let's see.
And in the years since the new millennium, the world has seen such progress. In 2000.
It is my hope that we get this video up.
And in the years since the new millennium, the world has seen such progress. In 2004, the tide was turned against AIDS. 2 years later, great strides against cancer. And tonight we celebrate a remarkable breakthrough in spinal cord injuries, made possible by countless researchers and contributors. And to present this award, we have some very special guests.
In the future, so many amazing things will happen in the world. What amazing things can you make happen?
I put that commercial there because it really is what all stem cell biologists want, to cure disease, to get patients out of their wheelchairs and get them walking again. So again, that's the hope. The expectation, though, is that it's going to take a while. Let me tell you where we are in stem cell biology now, and you'll see where we're going. So stem cells. You can think of stem cells as a tree, where embryonic stem cells here at the roots and the bottom of the trunk here will differentiate along different branches to make different cells in your body. So again, embryonic stem cells down here will form brain, tissue, nerve cells, muscle, blood cells, and they're all on different branches. So once a stem cell begins to differentiate along a different pathway, it's pretty much committed to that pathway. Scientists are now beginning to exploit ways of getting these cells back down the trunk and then up a different pathway. But in development, the way it normally works, embryonic stem cells will divide up along different pathways to become different tissues in your body. There are many different kinds of stem cells that you'll hear about and that you'll read about in newspaper articles, for example. There's embryonic stem cells. These are the stem cells that were originally used. They come from in vitro fertilization clinics. They're just a few days old after sperm and egg are mixed, and most of the science was done on embryonic stem cells for the past 15, 20 years. You'll also hear about neural stem cells because you're interested in neuroimmunologic diseases. There are stem cells in the bone marrow, as you heard from Richard Burt's. A lot of you were at Richard Burt's talk. And then there's a group here that represents, for example, stem cells that come from muscle and fat that maybe we can use as well. So you'll hear about all of these. Okay, let's start with embryonic stem cells. This is what a fetus looks like when it's a few days old. They're just a few cells. It all starts from one egg and it divides into several. Each one of these cells can form a human being on its own. If you pluck this off and grow it up, it will become its own human being. So it's considered totipotent, has unlimited potential to become every cell that you want, every tissue that you want. It can become organs. It can be, it has a potential to become anything, including, of course, spinal cord tissue, which a lot of you are interested in. One bad thing about this is, of course, harvesting this one cell may not kill the embryo, but it probably will. So you're almost necessarily destroying the embryo, which carries a lot of ethical implications, at least for the laws in the United States. Plus, what you're trying to do is you're trying to take this one cell that can form an entire human being, and you're trying to make it one tissue. So you're taking it from the bottom of the tree trunk all the way to the end of a branch somewhere else. That's a hard task to do. You're asking a lot. But again, that's our goal. The other choice that you have if you don't want to use embryonic stem cells is to wait till those embryonic stem cells differentiate on their own a little bit and collect them from a fetus. Again, controversial. You're using aborted tissue. Or from adults, from your own body. Everyone here sitting at the table has stem cells in their body, different parts of their body. For example, your liver has liver stem cells in them. Your kidney has them. Your brain has them. So there are attempts to harvest those stem cells from you, convince those stem cells to become what we want them to become, and then transplant them back into you. Ultimately, what we want them to become are neurons, which are the brain cells and the nerves in your spinal cord that do all the action. Astrocytes here are cells that support the neurons, and oligodendrocytes are cells that make the myelin sheath that allow nerve conduction down the axons. These are the cells we want to create. We can create them in the lab. We can form beautiful neurons and take pretty pictures of them in a dish, but as soon as we transplant them into an animal, into a new environment, they just die. It's really hard to take mature cells like these and just transplant them. The easier thing to do is to take the stem cell component of them before they differentiate and transplant these because they can move, they can adapt to their new environment, and they can then differentiate into any of these cells. Okay, so let me now differentiate between two different kinds of stem cells broadly. One is what Dr. Burt was talking about, hematopoietic stem cells. These are stem cells because they're not fully differentiated, and these are stem cells from your bone marrow that will become your immune system. Okay, and the field of hematopoietic stem cells is at least 10 years ahead of neural stem cells. And so they already have lots of clinical trials going on in hematopoietic stem cells. And the goal here is to replace the immune system. Okay, Dr. Burt's protocols will not regenerate your spinal cord. They will regenerate your immune system. Now, for some patients, that's what they need. But for others who are looking for regenerating their spinal cord, this is not where you want to go. Within the bone marrow, you also have another kind of stem cell called a mesenchymal stem cell, and we'll talk more about those. These don't form immune cells. These form, in the periphery, they form bone, fat, and cartilage. Now, as neurologists, we don't care about any of those tissues, but as neurologists, mesenchymal stem cells in their immature state turn out to be pretty cool. So we'll talk about these two kinds of stem cells from the bone marrow. Again, this is not regeneration of brain tissue. So Dr. Burt's protocol, for example, which is similar to a bone marrow transplant, harvests stem cells from your body, from the bone marrow, and he only takes the good ones. Then he wipes out the rest of the immune system as well as he can, and then reimplants those few good stem cells back into you. And hopefully your immune system will reconstitute from your few good immune cells so that your autoimmune disease will stop attacking your spinal cord and your brain and your optic nerves. That's the goal. And it turns out to be pretty good for patients who have relentless autoimmune disease, where their immune system attacks their spinal cord and brain and optic nerves over and over again, as in MS, for example. This turns out to be a pretty good choice for patients who can't be controlled on traditional medications. The reports are 50 to 80% progression-free survival. So these are patients who survive often without even requiring medications or a reduced dose of their medication. Dr. Burt was talking about improvement in these patients. The idea is if you stop inflammation for a few years, you give the brain and you give the spinal cord a chance to heal on their own. And Dr. Burt reports a pretty good improvement in some of his patients. The big problem with bone marrow transplants is the mortality risk. There are a lot of patients who, because you're wiping out the immune system, develop opportunistic infections. These are heavy-duty chemotherapies that you're going to take if you do one of these bone marrow transplants. And because of that risk, there's a lot of doctors who don't really want their patients to take the chance of doing a bone marrow transplant if they're not 100% sure it's going to work and if there are other options for you. The younger you are, the less likely you are to die from this. So if you're otherwise young and healthy, you may be a better candidate. If you have a lot of other medical problems, you probably don't want to do a bone marrow transplant. So again, for my patients, if there are other options that are less risky, then that's what I would prefer. But on occasion, I have, for example, sent a patient up to Northwestern to be considered in a trial. So the two clinical trials going on in the United States for this type of bone marrow transplant using stem cells from your bone marrow are going on at Northwestern with Dr. Burt. He, by far, has more experience than anyone in autoimmune diseases. And then there's one going on at the NIH. And I put this cartoon up. It says, "Since my bone marrow transplant, my dog doesn't know me." I put this on here because it's really not true. Because you're getting your own bone marrow cells back. Okay, this is not someone else's bone marrow. This is your own bone marrow. We select for the good immune cells, and they're going right back into you. So I mentioned another type of stem cell in the bone marrow. Again, they're called mesenchymal stem cells. We don't want them to become these tissues as neurologists, and as patients, you don't want them to become these tissues. But you're very interested in these mesenchymal stem cells because, as it turns out, they have some sort of immune calming effect. We don't really understand how it works, but when you take these mesenchymal stem cells out of a mouse bone marrow and you inject them back into their bloodstream, in a disease state, say they have an MS model, a model of MS called experimental autoimmune encephalomyelitis, these mesenchymal stem cells will just calm the immune system down. And it's been so effective. In the past few years, there have been a whole number of papers, this is just, I think, the past 3 years, showing that injecting these mesenchymal stem cells into the bloodstream of mice that have an MS-like disease, you can pretty much cure the disease. They're injected, and 1 hour later, these mesenchymal stem cells are already out of the bloodstream. They're gone. You can't detect them anymore. We don't even know where they go. But their effect is much longer lasting. So these mice would typically have disease for a month or so. You inject these stem cells, and they heal much faster. Now, their spinal cords don't heal. They still have lesions there from the events before you gave them the stem cells. Their brain has lesions there. It doesn't regenerate brain or spinal cord, but it does wonders for the immune system. So how would this work in humans? It's pretty easy. We would, again, just harvest these cells from your bone marrow, inject them back into your bloodstream, and then see how you do. There have been 2 trials that are already completed, one published. The one from Iran is published. Only 1 out of the 10 patients actually got better. About 4 of them stabilized, and 5 of them continued to not do so well. Now, despite the not so great efficacy data, the safety profile was excellent. It's literally just taking some of your blood and putting it back into you. That's kind of the equivalent. So no one had an adverse event. And again, if half of them improve, I think that's a pretty good effectiveness rate, or at least it didn't get worse. There's a trial at Cambridge that's following them for a year and a half, so we'll have to wait for those results. And then Israel is doing a trial where they inject these mesenchymal stem cells partly into your spinal fluid, like with a lumbar puncture, and then partly into your blood. See if that dual approach would help even better. Cleveland Clinic is going to start a trial pretty soon. They're going to enroll 24 patients. They're going to give you back your mesenchymal stem cells after they grow them up in the lab to make a few more. So they're going to take just a little bit out of you, grow them up and expand them into a large number, and then give them all back to you at the same time. And then they're going to follow you for a month, just 1 month, see how you did, and we'll see how that works. In Canada, I think they're still working their protocols out. Okay, so we've talked about how to restore or calm down the immune system using stem cells. Now let's talk about how to actually regenerate spinal cord, regenerate brain, and regenerate optic nerve. And we'll start with embryonic stem cells. Again, this is the one that has been used the most. We get them from IVF clinics. We pick them off after 5 days after fertilization. And then we culture them in dishes, in Petri dishes in the lab. And depending on what kind of growth factors you expose them to, you can make these embryonic cells become different cells that you're interested in. You can make them become neurons, astrocytes, and oligos. Again, these are the cells that do the work. These are the cells that support the neurons, and oligos make the myelin. Again, the ultimate goal is you want to transplant them into spinal cord to actually regenerate these cell types. Embryonic stem cells, again, have the potential to form any cell that you want. You want them to become neurons, oligos, and astrocytes, so you have to do a little bit of manipulation to keep them on that track. The problem is embryonic stem cells can form any kind of tissue, and they don't always listen to you. I can tell a stem cell, I want you to become a neuron, I want you to become an oligo, but they have a mind of their own sometimes, and they become different tissues. They can form hair, they can form teeth, they can form, you name it. And if you end up with a tooth in your brain, it's not exactly going to help. So they're a little bit hard to control, but again, these are the cells that have the unlimited potential, so they're particularly interesting to us. Geron has managed to create a cell line from embryonic stem cells that will only form oligodendrocytes, that will make myelin. And what they're planning to do is to take these cells and implant them into the spinal cord of a traumatic spinal cord patient. So this doesn't necessarily apply to my patients because they all have autoimmune diseases. They're looking for a traumatic spinal cord patient. They'll implant the stem cells directly, surgically, into the spinal cord and look to see if those cells can remyelinate. So although this trial isn't for most of us, we should really pay attention to the results, because this is the first time that a stem cell trial will try to regenerate spinal cord. Okay, so if you don't want to use embryonic stem cells because you don't want a tooth in your brain, there are other options. You can use adult tissue. Again, adults, everybody sitting here has lots of stem cells in their brain. There are adult stem cells. In the brain, there are basically two areas that are most popular. There's the olfactory bulb here right at the front basal part of the brain. These are the cells that you use to smell. They send their neurons down into your nose, and they can replicate, and they do your whole life. And the idea is maybe these neurons that go into your nose, if we transplant them into a different part of the brain, maybe the environment will convince them to become a motor neuron or a thinking neuron or a visual neuron or some other kind of neuron, which would be really great, because that means that everyone here has their own stem cell factory. You make tons of these, and maybe it's just a matter of transplanting them into the right place. The other area of your brain where you have your own stem cells is deep inside the very center part of your brain. These stem cells deep in here can migrate long distances, and they often do, and they're called endogenous stem cells, and probably in most of you who've had transverse myelitis or MS, these stem cells have come to your lesion and then have stopped and not remyelinated or just hung around there. We don't really know why. They get to the lesion correctly, but then they don't do anything. So again, that's another active area of research, but maybe it's a matter of taking these stem cells out of here, differentiating them in our culture, in our dish, in the laboratory, and then putting them back. And let me just mention one huge plus of using adult stem cells, either from here or from inside your brain. The big plus is these are cells coming from you, and they're going back into you. So you don't have to use transplant medications to suppress the immune system. Embryonic stem cells, in contrast, they have their own immune identity. They didn't come from you. So your immune system is going to try to attack it, and we'll have to give you transplant medications to suppress that immune response. But with adult stem cells, we won't have to do that. I think this is a good time to mention a very new topic in stem cell biology, only as recent as 2006, 2007, that is basically going to change stem cell biology and debate. I'm surprised this hasn't come up in Congress yet, because this is really going to change the way we think about stem cells. They're called induced pluripotent stem cells, IPSs. And the idea here is you take a skin cell or some other just cell from your body, easily accessible cell, and you make it go back in time in development. You take it back to an embryonic-like state, so that then you can make that embryonic-like cell into something else. And a group in Japan first showed that this is possible in a mouse back in 2006. They took a fibroblast, which is just a connective tissue cell from under the skin, and they took this cell, and they exposed it to a few growth factors and proteins, and made it go back in time in development. And then they reimplanted it into the mouse and showed that this cell can form cartilage tissue in your joint, even brain tissue, muscle tissue, fat tissue, skin tissue, whatever it wanted to. It was just like an embryonic stem cell. And then in 2007, they showed that they could do this in a human cell. So this is a huge breakthrough, because now we have access to embryonic stem cells without IVF clinics, without destroying an embryo. This would necessarily come from you. It would come from your skin and go right back into you, again, avoiding immune transplant drugs as well. So whether you're going to use induced pluripotent stem cells, or you're going to use embryonic stem cells or adult stem cells, eventually what you want to create are neural stem cells. Neural stem cells will form neurons, astrocytes, and oligos. And this is the beginning of the branch point. When you take embryonic stem cells or adult stem cells and you try to create neural stem cells, what you get are these floating balls, essentially, of neural stem cells. They don't really stick to a dish. They just kind of form these balls and they float around, and you can literally pick them from a dish and then transplant them into mice, which is what has been done in models of MS. And this is, again, one of those neurospheres. It's stained. The green stain is of those neural stem cells. And when they inject them into EAE mice, what they find is actually regenerating neural tissue. These cells will become a few neurons, a whole bunch of astrocytes, and some oligodendrocytes, which was really exciting. Now, it turns out the mice that got the cells that turned mostly into oligodendrocytes, they're the ones that did best in this MS model. The mice that got the cells that mostly became astrocytes, they really didn't do as well. And then it was kind of hard to create the neurons, but a few mice did make neurons from these neural stem cells. So one really hard task in using neural stem cells is we have to get them from your brain. So you're going to have to trust me to insert a big needle into your brain, take out some of these neural stem cells, grow them in the lab, pluck them out as they become neurospheres, and then inject them back into your brain. That's asking a lot. And so there are better ways to do this. Stem Cells Inc. is using neural stem cells in a different model of neurologic disease called Batten's disease. It's a pediatric disease, and they've shown quite a bit of success using neural stem cells. And Reneuron Limited is a company in the UK using neural stem cells in stroke. Again, the attraction of using neural stem cells is that they can form all three of those tissue types: neurons, oligos, and astrocytes. If you just wanted to form neurons, you could potentially take neural progenitor cells, which will form neurons, and it won't form astrocytes or oligos. And so if that was your goal, and that I think it's been looked at a little bit, then you can try using, neural progenitor cells. This hasn't really gotten a lot of attention. And the reason is because if you just create neurons, you don't really have a way of getting the neurons to talk to each other and connect. You're just creating a bunch of neurons that kind of just sit around. So that's been more of a challenge because neurons have to grow. They have to send these processes up to connect above them, and they have to send this process down to connect below them, which is, again, asking a lot. But that is something that Dr. Kerr was working on when he was at Hopkins, and I think it's a little bit farther into the future. So we have another option, though. If you just want to make myelin, for example, a lot of my transverse myelitis patients have neurons. They don't need any of those. They just need myelin. They need to remyelinate their spinal cord lesions. And so one option for these patients is to use glial restricted progenitor or precursor cells. I'll just call them GRPs. GRPs are one step down from neural stem cells, so you can take neural stem cells and make GRPs from them. And then these GRPs can become either astrocytes or oligodendrocytes. Now I'll tell you, for transverse myelitis, you probably want oligos. For neuromyelitis optica, you may want both of them because you may have an astrocyte-based disease, and that may turn out to be beneficial for you. Again, one step below GRPs are astrocyte precursor cells and oligodendrocyte precursor cells, and both of these are transplantable. The trial I was telling you about in traumatic spinal cord, they used embryonic cells to create neural stem cells to make GRPs, and then took them to this stage, the oligodendrocyte precursor cell stage, and then they convinced them to stop. They froze them down, and this is what they're going to ship to us when we get a spinal cord patient. And this is what we'll transplant into those patients. And these GRPs that can form both oligos and astrocytes have amazing potential on their own. What I'm showing here is a picture of myelin. These dark black rims are myelin from a mouse that isn't supposed to make myelin, but that got injected with these GRPs. And they made myelin very well. And they made myelin throughout the brain and the spinal cord, and it was life-changing for these mice. Instead of dying early, they lived almost normal lives. So these GRPs are very exciting. In EAE, in an inflammatory state, these GRPs don't work the same. And so it turns out the environment is really important. If you have an inflammatory environment, the GRPs may need a little bit more manipulation to become myelin. If you have a genetic model, these GRPs tend to know what to do. Another great thing about these GRPs is since they're destined to only become astros or oligos, you're not going to get teeth in the brain. You're not going to get abnormal tissue growth. They are much better at not forming tumors, for example, than embryonic stem cells. So again, this is what we're working on in the lab. One thing that we're doing at Hopkins is we're trying to avoid having to do surgical injections. A lot of our patients have longitudinally extensive lesions, or up and down the spinal cord. A lot of them have brain lesions and optic nerve lesions, and you really don't want me to stick a needle in there. So another way to deliver these stem cells is to try to get them through the bloodstream to target to the right place. So I would inject it into your bloodstream, and hopefully these stem cells can get to your spinal cord, can get to your brain or your optic nerve, wherever you need them. So that's what we're working on in the lab. And I just wanted to end with this. This is, again, our expectation is to eventually take these stem cells to trial. This is a mouse sitting on a psychiatrist's bed. It says, and the psychiatrist is saying, I believe I have a new approach to psychotherapy, but like everything else, the FDA tells me it first has to be tested on mice. So most of the work that we do and that I've shown you has been done on mice. The next step is to take it to a larger animal, and that's something that we've started doing, and then eventually to our patients. Thanks.
So we have a couple minutes for questions on the stem cell side of things. I thought we'd try and put as many of those questions now, and then if more come up during the panel on, focus on the stem cell side. So in the back.
Wouldn't that
Yeah,
be more
good
productive?
question. I asked Dr. Britt, let me just repeat the question. The question is, if a patient has a disease and you're going to do a bone marrow stem cell transplant on them, why do you want to harvest their own immune cells when that's the problem to begin with? Is that a pretty good summary? So I asked Dr. Britt that. I said, why do you take these patients' own immune cells? Why don't you take it from a donor who doesn't have MS or NMO or any other disease? And he says that the complication rate is much higher because you're introducing a new immune system into your body. You have graft versus host disease. That's where the donor's immune cell starts attacking the body, different tissues in the body. And so it creates its own host of complications. But I think that that would end up being more likely to cure a patient than to manage a patient, which is the goal of the autologous bone marrow transplant, which is taking your own cells back. Good question.
Other questions? Yeah.
Okay, I'm sorry?
So are there any comments on the company NeuralStem?
Neural stem.
So this is Eva Feldman's the PI of the trial. This is a group doing the ALS trial enrolled at Emory.
Oh, that implants stem cells into the lower spinal cord?
So lumbar spine, anterior motor neurons.
Yeah, I think that that's more of an experiment. What they're trying to do is see what happens when neural stem cells are injected into the spinal cord to see if you can regenerate neurons in those patients. They won't live longer because this is just the lower part of the spinal cord that doesn't, help you breathe. But the idea is what happens when you inject fresh stem cells into a hostile environment. These patients with ALS, have a spinal cord that's not very amenable to stem cells. And so the question is, can you change the environment, and what happens when you put those stem cells in? So I think it's more experimental right now than actually, knowing what we're doing. But I think the results will end up helping us guide our future stem cell trials.
Michael, I wonder if I could add a couple of comments to really emphasize the point that you made. Because I think one of the real misconceptions amongst patients in regard to embryonic stem cell therapies is that it will be embryonic stem cells themselves that are used. And although you went over this many times with regard to the dangers that ES cells have in the formation of tumors, you said teeth in the brain, et cetera, I think people still don't quite grasp the idea that the preparations that will be used have to be absolutely devoid of any embryonic stem cells for the FDA to approve it. So there's always this background that thinks that we're actually going to use the embryonic stem cell itself. But it is, as you said, it's a pluripotent cell. On its own, it's very dangerous. And this is why Geron had to go to huge lengths to prove that within their population of cells that they're going to transplant, that they're completely devoid of these cells. And this is difficult to do. This is a really tough scientific challenge that Geron and other companies face when they're going to do this. So you have to realize it's not ES cells. It's cells differentiated from ES cells with completely pure populations. And then the second thing is that the company that you said, Stem Cells Inc. in Batten's disease, they've now started a trial in a myelin-specific disease, in the childhood X-linked disorder, Pelizaeus-Merzbacher disease. So although for the moment it's just a safety phase 1 trial, I mean, their goal is to have those cells form myelin, which of course is, as you pointed out, is one of the major interests of people here. So they're closer there than with neural stem cells that will have interest in applications here.
For patients who don't know who that is, that's Dr. Duncan from Wisconsin, who's been working on stem cells for 20 years.
Oh, come on, that's wild.
Sorry. Doesn't look a year over 21.
And Michael, can I ask you a question? Because this comes up in our clinics all the time. If you look at the Geron trial, which is the one doing spinal cord injury right now, one of the things that makes it challenging is they are looking for patients who are no more than 14 days out from their spinal cord injury. So somebody has an injury and then they have to have implantation occur somewhere between 7 and 14 days after the injury. And one of the questions that comes up is, in terms of the trials we're talking about, how are we going to deal with issues related to for our folks close to the event, transverse myelitis in a situation or optic neuritis, versus people who had their event a decade ago? And is there any work that you know of trying to look at people who had the event a decade ago?
Yeah, that's a good question, Ben. The idea, again, is the environment. So in a patient who just had a spinal cord injury, at 7 to 14 days in, the goal there is within the first 7 days, you have some inflammation. Okay, so let's avoid that. Beyond 14 days, you start to get scarring. We want to avoid that. So we have a window there between 7 and 14 days where you can implant these stem cells and hopefully not have any of the problems of inflammation or scarring. I mean, that's the goal there. The goal is to try to make this work. With patients who've had transverse myelitis for years, your spinal cord probably has a significant amount of scarring there, so that's going to be a challenge to overcome. A lot of the patients with monophasic transverse myelitis who've had it one time, though, we don't have to worry about inflammation recurring over and over again. You just had that one bout, you don't have an autoimmune disease anymore, and it might be easier in monophasic transverse myelitis, for example, than it would be in MS.
Any other questions?
Is avoiding the inflammatory environment the reason you said that these cells haven't been tried in EAE mice so far?
No, so the reason they haven't been tried yet is because I'm working on that now. It's going to be tried. That's not the issue. The goal is to use these cells in an inflammatory environment and figure out a way around the inflammation, or even to use the inflammation to our advantage.